So I'm here with Dr. Kiarna Brown, who gave a really amazing speech this morning at RANZCOG Day 1 about closing the gap in O&G. You told us a beautiful, very sad, but very beautiful story to sort of kick off your talk. Could you share a little bit of that with us?
Yeah, it's a story about a young woman, 19-year-old woman, who'd been transferred to my hospital from a very remote Aboriginal community with something completely unrelated to actually what was going on for her health-wise. So she came in with a sore ankle because she'd unfortunately been hit by her partner with a rock to her foot, and she needed to come in because she developed cellulitis. But as a side note, she was also noted to be pregnant, about 19 weeks, with not much antenatal care. Her story was long and complicated. There were lots of social things going on for her, as well as her health issues. But as it went, she'd been diagnosed with an autoimmune disease a couple of years back, and she came in. She initially got treated for the cellulitis, but then she disappeared from the hospital before her treatment was complete and before she could be transferred back home. And then she came back the following day with some unusual behaviour. Her sister had brought her in and said that she was having some auditory hallucinations and she was acting strangely. And she'd admitted to smoking marijuana that day, and they thought that possibly she was having a psychosis related to that. But actually, she got really sick while she was in hospital. She was obviously having a flare of her autoimmune disease, and it was misdiagnosed in her initial presentation. And so she ended up getting pretty sick and having a 40-day admission that had stemmed from first her ankle and then her psychosis and then an obvious flare of her autoimmune disease. Then the other layer of it was that she just kept saying how she wasn't crazy, how she just wanted to go home, how she felt scared in hospital, how she felt anxious and teary, and how much she didn't want to be there. And eventually she was discharged. She was kept in the city where I work, and then I met her a week later. And unfortunately, she was really unwell. She was 29 weeks pregnant, and she was clearly having a bad flare of her autoimmune disease. Her blood pressure was up, her platelets were down, her creatinine was up, everything was going wrong for her, and so we had to make a decision to deliver the baby preterm. She ended up in ICU. She had a long, complicated admission, and again, she was eventually discharged. And my story says that a couple of months later, I was due to go to her community for an outreach visit, and the nurse who comes out with us said to me, "Oh, this girl's name's on the list. Why is she on the list? She's dead." And so at the tender age of 19, a new mother with, probably a misdiagnosed illness, her life ended.
And what was it about that story that you wanted to share it? I guess it sort of illustrated some things you went on to talk about.
Yeah, so I guess the things that I wanted to share was just the complexity, the layer upon layer upon layer of complexity that we're dealing with Aboriginal health. And actually, the thing that I'm learning as I'm going through, as I work every day, is that for Aboriginal people, it's not about illness. It's not about the ankle. It's not about the kidneys. It's not about the sugars. It's about deep cultural strength. It's about connection to community. It's about connection to country. It's about being strong within ourselves, and then the health stuff comes.
And when you shared four kind of, I guess, pointers or four lessons to take from your presentation. Could you share those with us?
So what I wanted to do was make it a personal but a positive thing. I wanted people to go away and think, actually, I can contribute to closing the gap between health discrepancies between Indigenous and non-Indigenous Australians. And so, look, I had limited time. I came up with four, and the four were that you need to understand remoteness. And the point was not so much about geographical remoteness, but about racism and loss of culture and loneliness. My second point was about underservicing, and so what I wanted people to start thinking about was changing their mind frame about how health works in Indigenous communities. Like I said, just now, it's not about treating sugars, it's not about treating blood pressure, it's actually about treating the person or the community, it's about treating that person in a cultural context. My third point was about knowing your community, and I just wanted to illustrate to people that Aboriginal culture in this country is very diverse. There's not a one-size-fits-all model, that we have to take into consideration different communities. The needs of the women that I service are different to the needs of the women who live in metropolitan Sydney, for example. And people need to understand that. We can't close the gap by having umbrella, policies and programs that aren't going to work in specific pockets of our country. And the fourth point was about non-Indigenous people knowing their advantage. I wanted people to reflect upon themselves and say, I might meet an Aboriginal person, I might have all these preconceived ideas about who they are, but they don't actually reflect on who they are and how they're treating that person because of the privilege that they have more often experienced.
What do you think doctors in particular can and must do to address this situation?
So I think the important point that I tried to make was that every doctor can be culturally appropriate and culturally safe and provide culturally safe care to Aboriginal people. So if you look at the historical context, Aboriginal people weren't even allowed in hospitals, 1, maybe 2 generations ago. And so our modern doctor needs to understand that and needs to be aware that, it's their responsibility to be culturally safe and provide culturally appropriate care.
And what's the context in which we're having these conversations? You sort of illustrated some of the data or, the disparities that we're looking at.
Yeah. So particularly for Aboriginal women, because I work in Aboriginal women's health, we know that the burden of disease is worse: chronic disease, diabetes, hypertension, heart disease. We know that Aboriginal women are more likely to live less, so the discrepancy that is quoted at the moment in our country is about 10 years less than the non-Indigenous population. Our babies are born more often preterm, and in some parts of Australia, our preterm birth rate is double that of the non-Indigenous population, up to 14%. And the other thing that I said was that our babies are often born with lower birth weights. So they're already starting, 10 steps behind.
It's that race analogy that you gave, the running the race for the $100.
That's correct, yeah.
I encourage anyone who hasn't watched that video yet, we tweeted it earlier, you need to check it out.
Yeah,
it's really, it says everything.
It's powerful.
Yeah.
And it's a demonstration of something that you just can't put into words. You just have to see it. You just have to see how it unfolds. Yeah, so YouTube it, $100 race.
Yeah, and what can institutions do? I mean, you're obviously quite involved at the top end of RANZCOG about these issues. What can institutions do to address this?
So the institutions like RANZCOG can be really active in making changes. And, and the thing about being involved in RANZCOG is it's a powerful organisation that can have some real impact in health policy. So it's multifaceted. We need to ensure our trainees, our fellows, are culturally aware and provide culturally safe care. We need to grow our Aboriginal doctors and medical students and fellows. We need to make sure that health is inclusive of a well-trained Aboriginal workforce, and we're in a really good position to provide information on policy, on national level policy in terms of Aboriginal women's health.
And you had the Aboriginal and Torres Strait Islander Women's Health meeting this weekend, just before the conference.
Yeah.
Tell me how that went.
Oh, that was amazing. So the format of that conference has traditionally been that we get, Aboriginal health workers, midwives, people on the ground, in the front line, in the thick of it, working in communities, and coming together and sharing their stories. What programs are they doing? What research has been done? What do we know? What's new? What's everyone up to? And we had a great conference. We heard from amazing speakers, both Indigenous and non-Indigenous. We heard from Sky Parsons, who's a Aboriginal midwife who spent a lot of time working in central Sydney, and she shared her experiences. We heard from Professor Kerry Arabino, who's been working on the first 1,000 day movement, and how empowering community at community level will really make a difference in terms of growing elders for the future. And strong cultural elders, and we heard from Janelle Bowen, who's a social worker who also works in New South Wales, and she works on a really important program about around family violence and domestic violence, and what's happening in that space and how we can help women.
Sounds like a really exciting time to be working in this space. It's easy to get, I guess, feel a bit weighed down by the statistics and by the bleakness of it. But tell me how you're sort of looking at it, because it sounds like you have a different perspective.
Yeah, I think the thing about where I'm at in my career is that I know that I will hopefully see change. And I know that we're recruiting enough people and changing enough mindsets that we'll get all these people on board. We'll get more fellows on board who will want to make a change as well. And the only way we can do it is together. We can't rely on Aboriginal people to change Aboriginal health statistics. And I really feel like that people are becoming more aware, becoming more enthusiastic. And I really hope that by the time I retire, I see some change in those statistics.
Yeah, me too. Thank you for your time.
No worries. Was that okay?